Fall prevention, reduction, and management for nursing assistants. The definition of a fall. A fall is a sudden, uncontrolled, unintentional, non-purposeful downward displacement of the body to the floor, ground, or hitting another object like a chair or stairs. Classification of falls. Accidental falls, anticipated physiological falls, unanticipated physiological falls. Accidental falls. These are caused by environmental factors or errors of judgment made by the patient. These patients may not be initially identified as being at risk for falls based on the Moore's Fall Scale. Anticipated physiological falls. These falls occur with patients identified as fall prone by scoring at risk of falling on the Moore's Fall Scale. These falls are caused by physiological reasons that include a combination or all of the following: more than one diagnosis, a witnessed or unwitnessed previous fall, a weak or impaired gait, lack of realistic assessment, judgment, or an ambulatory aid. The Moore's Fall Scale is a predictor of this classification. Unanticipated physiological falls. These falls may be due to physiological causes, but are created by conditions that may not be predicted before the first occurrence. For example, seizures, feigning, or a pathological fracture of the hip or leg. Definition of a near miss. A near miss is an interruption of a complete fall, such as a trip, stumble, slip, or loss of footing, with recovery and being caught before hitting the floor. A patient that is caught in a mid-fall but eased gently to the floor is to be considered a near miss. Fall prevention and management interventions. Low-risk patients. Orient patient to surroundings and assign staff. Ensure lighting is adequate to provide safe ambulation. Provide yellow, non-skid socks and educate patient on their use. Instruct to call for help before getting out of bed. Demonstrate nurse's call system. Ensure the call bell is within reach, visible, and the patient is informed on the location and use. Ensure the light cord is within reach, visible, and the patient is informed of the location and use. Provide physically safe environment. For example, eliminate spills, clutter, electrical cords, and unnecessary equipment. Personal care items should be within arm's length. Place the bed in the lowest position with the wheels locked. Assign a bed that enables the patient to exit towards the stronger side whenever possible. Room placement should be closer to the nurse's station. Initiate transfer procedures as appropriate to the patient. Use side rails as needed, bed alarm, wheelchair alarm, bedside mat. Ambulate as early and frequently as appropriate for the patient's condition. Educate patient on ambulatory category. Instruct the patient in all activities prior to initiating. Instruct the patient in the use of grab bars. Individualize equipment specific to the patient's needs. Every 1, 2, or 3 hour comfort and toileting rounds. Comfort rounds include positioning as indicated, offering fluids, snacks when appropriate, and ensuring the patient is warm and dry. If required, use an elevated toilet seat. Diversional activities. Minimize distractions. Educate and supply patient and family with fall prevention information. Check tips of canes, walkers, and crutches for non-skid covers. Use bed exit alarm. Fall prevention and management interventions for high-risk patients. Use appropriate interventions previously listed and provide hip protectors. Identify patient with fall risk yellow wrist, leg band, and yellow non-skid socks. Place a falling leaf outside the patient's door. Place a falling leaf over the patient's bed. Place a falling leaf on the back of the patient's wheelchair. Ensure you place the patient's bed in the low position. This is the Moore's Fall Scale that was previously mentioned. The nurse uses this to assess the patient's risk for falls. There are 6 categories: history of falls, secondary diagnosis, ambulatory aid, IV or heparin lock, gait and transferring, and mental status. The nurse will take the scores from the Moore's Fall Scale and place the patient in one of the 3 categories. A score greater than 51 is high risk, low risk is 25 to 50, and no risk would be 0 to 24. Patients identified as low risk. The fall prevention and management interventions will be implemented as deemed appropriate. Falls interventions will be documented in CPR-S by the nurse. For those patients that sustain a fall or a near fall, the nursing assistant will notify the charge nurse. The patient shall be evaluated and treated by the attending or designated physician on call, and recommendations for additional interventions shall be made and the plan of care revised as needed. Pre-fall responsibilities. Nursing staff. Implementing fall interventions when a patient is at risk for falls, assuring placement of falls risk yellow patient arm leg band and a yellow non-skid socks, assuring the falling leaf is placed over the patient's bed outside the patient's door, and if appropriate on the wheelchair for a high-risk fall identification. Post-fall management protocol. Nursing interventions. Assesses the patient for injuries without moving the patient. Assesses vital signs, including orthostatic vital signs, unless the injuries prohibit it. If the patient is diabetic, check a blood glucose level. Determine circumstances leading to the fall. Notify the physician or medical provider that a fall has occurred. Then initiate any additional falls interventions to prevent further falls. Documentation. Details and circumstances surrounding the fall. You should document the vital signs, date and time of fall, patient's appearance in response to the event, assessment of the injury, location of the fall, the medical provider that was notified, any medical or nursing actions, date of the last fall if known, and any environmental factors. The nurse will initiate an EPR document with the full details and notify the physician of the EPR report number. The nurse will reassess the falls risk using the Moore's Fall Scale on the post-fall note. The nurse will alert the interdisciplinary team of the fall incident. The nurse will continue to assess the patient for latent signs and symptoms of injury. The patient must be made a first priority. The nurse will reassess every 4 hours for 24 hours. Nursing staff must document findings in CPRS using a post-fall note. When the LPN is in charge of the unit, the nursing supervisor and manager must make the assessment and document the findings in CPRS. The supervisor or manager will document the incident on the 24-hour report.